Oh, good morning, and thank you everybody for joining UT Health San Antonio Pediatric Grand Rounds. As you log on, please don't forget to mute your devices. Also, the participation code will be placed in the chat box periodically, so you can check there. Otherwise, it is my absolute great pleasure to introduce our speaker for today, Dr. Whitney Rose Schwartz, who is a little bit post-call. So excuse any jarbled words, but otherwise, she's here. She's here now. We're grateful for her. Dr. Schwartz is currently an assistant professor for pediatric emergency medicine here at UT San Antonio. She was both a medical student and resident here at UTESCA prior to going on to her emergency medicine fellowship at Dell Children's in Austin, Texas. And I'll add, quite frankly, that my favorite resident ever working with her. For those of you who know her, worked with her, uh, literally see her skipping down the hall during rounds because that's the energy she brings. And let's see, somebody needs to mute. All right, thank you. But yes, so happy to have her back here. Dr. Schwartz currently does QI work for the, whoever just logged on, could you mute, please? There you go. Yeah. She currently does QI work for the Pediatric Emergency Department and is one of the projects she's working on with Dr. Andrew Meyer is on the PECARN TPOT study regarding the use of nebulized tranexamic acid. Did I get that right? For post-tonsillectomy hemorrhages. Otherwise, everybody, please welcome Dr. Whitney Rose Schwartz.
Thanks, everyone. Thanks for having me here today. So, yeah, like Dr. Ranch said, Whitney Rose Schwartz. I'm one of the pediatric trained PEM providers here at UT. And we're going to talk about pediatric sepsis, updates, and changes at university. And for the residents out there that are multitasking, you don't have to today because this is a little bit of a shorter presentation. So you can put down your other work and listen in, and you'll have time later to do your patient work. Okay, so on that note, let's begin. Disclosures. I have no financial disclosures, just children. These are my nuggets. Of course, I had to include them because I'm the mom. Morgan, Madison, Sydney, and Wynn, 2, 4, 7, and 8. But now we'll get to the topic at hand, sepsis. Okay, so sepsis, as we all know, is a big problem. So worldwide, it affects about 25 million people, 3 million mortalities worldwide. In the United States, it's about an 8% mortality rate in the United States. So big deal. In this presentation, we're actually going to talk a little bit backwards. We're going to talk about the definition of sepsis, how we track it, and then how we screen for it. And we're going to do that because early identification of sepsis is really challenging. And so I think this will kind of help demonstrate that. Additionally, for our learners out there, I know sometimes this kind of seems like a womp topic, definition, tracking sepsis, but it's really important. And I know on the day-to-day, you learn a lot of great bedside direct patient care stuff, but sometimes it's really important also to learn kind of like the bigger picture of things. And so I think this presentation kind of touches on those topics. So on that note, let's talk. So we talk about sepsis. Every disease process needs a standardized definition. You need a standardized definition so that you can study that topic, and then from there you can improve outcomes. Okay, so it's really important to have a good standardized definition to be able to study the topic and then improve outcomes. Just as important, that definition needs to be applicable on a worldwide scale, right? Both first and third world countries need to be able to use that definition. So sepsis has gone through many iterations of definitions throughout the year, and no surprise, it will probably continue to go through other iterations in the future. So we'll kind of skim through some of those iterations. So in the 1980s, it was sepsis syndrome. Hey, you have concern for infection and there's some sort of organ dysfunction, poor perfusion going on. That was it. In 1992, you had your first international sepsis conference, Sepsis 1, that kind of put a more formal definition to sepsis. And so Sepsis 1 said, hey, sepsis is a suspected or confirmed infection in the presence of the systemic inflammatory response syndrome, SIRS. So suspected or confirmed infection in the presence of SIRS. SIRS meant you had 2 out of 4 abnormalities in the following: temperature, heart rate, respiratory rate, white blood cells. Then you had severe sepsis, septic shock with different levels of in-organ perfusion and need for pressors or rising lactate. Don't worry about that part for right now. SIRS, as we all know, was it 30 years later, is not great. Cannot differentiate between sick or not sick. And so we really don't use it for that reason. But that's what you will hear a lot about in the world out there is SIRS. And that's what that means. So that was a start. 11 years later, they met again. I had the Sepsis 2 conference, and for all intents and purposes, they kind of clarified some signs and symptoms recognized and started talking a little bit more about the host response. And we'll kind of leave it at that for that conference. Up to this point, this has all been adult definitions, nothing pediatric specific. And in 2005, you have the IPSCC, the International Pediatric Sepsis Consensus Conference. And they met and kind of put a pediatric definition to it or spin on it. And they kind of defined what the organ dysfunction was a little bit more and then added pediatric age vital signs. Notably, they noted, hey, we got some limitations here. This includes mild illness, right? The SIRS, right? Does not identify those at risk for poor outcomes. There's study discrepancy in how the clinical criteria are applied, which we'll see a little bit more about in the future. And then it hasn't been studied globally. So progress needs more. So in 2016, we had the Sepsis 3, and this is big. This is the first time you have more scientific data to support what's going on. They did this process through many different ways. You can read the paper for information, but in short, they said that sepsis is now a life-threatening organ dysfunction caused by a dysregulated host response defined by a SOFA score of 2 or more. SOFA being sequential organ failure assessment. So they're kind of making more solidified, like what is organ failure? How are we defining that? And how are we defining that? So again, a life-threatening organ dysfunction caused by a dysregulated host response defined by a SOFA score of 2 or more. Septic shock, you needed pressors or an elevated lactate. There was QSOFA, quick SOFA. It was attempted to be a 3-organ system screening tool, kind of shorter version of SOFA. It's not sensitive at all, so it's not a good screening tool. And then they said, hey, this is not pediatric data, but they put a PSOFA and said, hey, we'll put pediatric vital signs, and that's a PSOFA. Notably, the Sepsis 3 conference said, hey, pediatrics, you really need to do this something similar, but with pediatric literature and pediatric research. So come 2024, you have the International Consensus Conference for Pediatric Sepsis and Septic Shock, and they came up with the Phoenix criteria. So this is super important. This is where you want to really listen in, everyone. So sepsis in pediatrics is now defined as suspected infection with life-threatening organ dysfunction defined by a Phoenix sepsis score of 2 or more. So again, pediatric sepsis is now officially defined as concern for infection with life-threatening organ dysfunction with that organ dysfunction defined by a Phoenix sepsis score of 2 or more. Shock, septic shock, is when you have the Phoenix sepsis score with at least 1 in the cardiovascular section, okay? The Phoenix score applies to those less than 18. It does not apply to newborns or neonates less than 37 weeks. And again, we're not using SIRS, we're not using severe sepsis, okay? Notably, the Phoenix score helps with the definition of sepsis. This is not a screener, and it's really important that people understand this. This is a definition, not a screener. Those are 2 very different things. So this is the Phoenix sepsis score, the table to help you calculate it. So it's 4 organ systems: respiratory, cardiovascular, coagulation, neurologic, and it says, hey, sepsis, suspected infection, Phoenix score of 2 or more, septic shock, sepsis with greater than 1 in the cardiovascular. Notably, the original Phoenix sepsis score had 8 organ system models, but when they compared the 8 to the 4 system model, they had comparable, they were very comparable. And so for increasing utility, they decided to go down to a 4 organ system model rather than an 8 system model. The 8 system model included renal, endocrine, immunology, and hepatology. So just kind of side note there. Now, when they did the Phoenix score, the authors, they say, hey, we have some limitations. This definition simplifies the complex biological processes leading to sepsis. It simplifies the variability in host and pathogen factors, and it does not characterize specific markers of dysregulated host response. So, newsflash, we're going to talk about the future in a bit, and those will be some of the topics we talk about. So, progress, steps in the right direction, we need more steps. Okay, so now that we've talked about the definition of sepsis, concerned for infection with evidence of end organ damage defined by a Phoenix score 2 or more, how do we track and measure that data? How do we track and measure it? This is a lot harder than meets the eye. And so I think if you read Pediatrics 2021, the IPSO Collaborative, you'll kind of gain some insight into how challenging this can be. And for anyone who tries to do sepsis work at a future hospital, I really highly encourage you to read this paper because it'll give you a lot of insights into the challenges so you don't have to repeat them. So IPSO stands for Improving Pediatric Sepsis Outcomes. IPSO, Improving Pediatric Sepsis Outcomes, and I'll use that term throughout this presentation. It was a 56 U.S. hospital collaborative, and they tried to develop variables, metrics, and a data analysis plan to track QI-based patient outcomes, specifically related to sepsis. Okay, so when you try to do this, you need some metric development. So different metrics need to be thought about. So one is outcome metrics. Is what I'm measuring truly matter to my patient, right? Sounds important. Process metrics. Does it directly influence outcome, right? That's really important. Does it directly influence outcome? Balancing metrics. What are my unintended consequences? Am I going to get user fatigue, right? So unintended consequences of what we're doing. Abstraction of metrics. We need to make sure that we can obtain the data, we can optimize it, and we can make it sustainable. So can we abstract that data easily? And is it reproducible and sustainable? Because if it's not, a lot of our effort's going to go to waste, right? And then lastly, our outcome and process measures must be effectively linked, which is a little bit repetitious, but I think it's really important because if you're trying to do process improvement, you need to make sure what you're measuring is actually affecting your outcome. Additionally, now that we have a lot more pay for performance out there, this is going to be more and more important. So this slide is a little busy, but that was my intent on this figure. So this figure demonstrates just some of the measures that IPSO is tracking. So these are some of the measures. They say, hey, these are the variables needed. And this is the statistical analysis to look at that. Same, this one's a little bit busy, but my point is a little bit in that sense too. So this figure says, hey, this is how IPSO defines the earliest point of sepsis recognition. And if you look at it, there are 6 different times that they identify as time 0 for earliest recognition of sepsis. 6 different times for time 0. You're like, wait, what? And I think this alludes to the fact that sepsis is a very heterogeneous phenotype. It can be very hard to recognize early on. It's different than asthma. Asthma is a more narrow phenotype. Sepsis is this very broad heterogeneous phenotype. And so retrospective data collection can be really, really challenging. And oftentimes coding can be somewhat unreliable. Additionally, there's a lot of overlap with other disease processes. So making an automated system can also be problematic sometimes. So again, sepsis, heterogeneous phenotype. It can be subtle how it starts off. It's unreliable coding sometimes because of that, and it overlaps with other conditions, also making it challenging to do data abstraction. Hence, 6 different time zeros for earliest recognition of sepsis in the IPSO collaborative. Same, this one is how IPSO tracked, like, what are we saying is sepsis? So they had 8 different ways to identify sepsis retrospectively, which again goes to the fact that this can be really, really challenging. So that was a brief skimming over how we do data, or what the IPSO collaborative did for data tracking. But I think it alludes to the point that this can be really challenging to do. So we've talked about definition.
Oh, sorry, Dr. Schwartz, you got muted accidentally. Let me see. It won't let me fix that. You actually hit your space bar. There we go.
Oh, I did. Okay, sorry about that. Okay, could y'all hear me from this slide or no?
Right when you're starting the slide.
Okay, perfect. Okay, so now we're talking about screening. So we talked about definition, tracking, and now let's talk about screening for sepsis. So when a patient arrives in ED, you just have vital signs and their history and how they look, right? Sometimes not even that. We don't have the Phoenix score, which, by the way, the Phoenix score again is our definition, not our screening. And you might not have labs for hours, okay? So can't use that. I think it gives you insight that's challenging in that IPSO had so many different ways to recognize time 0. Screening is really challenging. And so in fact, it's so challenging that we do not have a standardized pediatric tool for screening for early sepsis. There's no standardized pediatric tool for screening for early sepsis. In fact, every children's hospital has slightly different versions, and some hospitals have one version for the ED and a different version for inpatient, hem-onc, and PICU. Okay, so challenging. When we talk about screening tools, they need to be accurate. So they need to have a high sensitivity, they need high sensitivity and high positive predictive value. They need to be timely. So it does me no good if you're like, the screen goes off and says, hey, you're septic. You're like, yeah, I'm on pressors, right? We need it to alert me in time to actually make change before things happen. It needs to be easy. If it's not easy, it won't be utilized, and that's just human nature. So what are we doing at university? So old UHS screening and mortality data. So in 2017, Pediatrics published kind of a screening, I say like recommended a screening tool, but it was pretty useless to put it best. So university had that screening tool, and these were our numbers. The sensitivity of that screening tool was 22%. So it identified 1 out of every 4 to 5 patients with sepsis. So that's not good. And the positive predictive value was 7%. So every time it said, hey, you have sepsis, if it did that 14 times, 13 were false positives. So not a great screening tool. Again, screening tools need high sensitivity, high positive predictive value, ideally. On mortality, university in 2023 was 16.7, 13.8 for pediatric attributed sepsis, and the national average is 8.2 per the IPSO collaborative. So then comes the wonderful Dr. Shanley. I don't know if she's on today, but in summer of 2024, Dr. Shanley started the Pediatric Sepsis Workgroup Initiative to help us with our screening, our processes, our tracking, and decreasing mortality rates. And she has done a phenomenal job, so all the credit goes to Dr. Shanley. She has created a team of many EPIC analysts and then a bunch of nurses and faculty from all different departments, from PICU, the floor, the ED, etc. So our goal was for us to redo our screening tool and then implement the IPSO metrics. So for screening, because there's no standardized screening, we decided to mimic CHOPS, which I think arguably everyone could say is not bad. So we mimicked CHOPS screening tool for the ED because that's where we started. And then we started with the building of some IPSO collaborative measures. So how does that look? So this is the PDED sepsis screening tool. We started this process about a year ago, so mid-February of 2025, and this is how we're screening for sepsis. So let's dive into it. So if a kid comes to the ED, if they have hypotension or tachycardia, EPIC gives the nurse an OPA. That stands for Our Practice Advisory. It was formerly known as a BPA. So hypertension tachycardia, the nurse gets a flag on her screen that says, stop, you need to do a PD sepsis screen. And if they have fever, hypothermia, or infection suspected, plus one of the following, abdominal perfusion, altered mental status, a high-risk condition, then it flags a second OPA that says, stop, you must do a sepsis huddle. And that means within the first 15 minutes, within 15 minutes of that huddle being triggered, the nurse and the ED faculty specifically, not residents, faculty must meet at bedside and determine the outcome of the huddle. Are they not sepsis, green, not sure if they're sepsis, yellow, or sepsis, red, okay? And we'll get into that in a bit, green, yellow, red. So again, a 2 OPA trigger to do a sepsis huddle. Now, at any point during this, if a nurse is like, hey, I'm concerned for sepsis and they're not triggering the sepsis huddle, they can automatically trigger a sepsis huddle themselves. And that's what you'll see on the right-hand side of the screen. And this applies to a lot of our at-risk for sepsis patient population. And I'm going to use that term at risk a lot throughout the presentation. And what I mean by that is that are immunocompromised and fever patients. So they may arrive in the ED and they look great. They have a fever at home, but they're not tachycardic hypertensive. But the nurse knows, hey, those kids need to get it worked up and have antibiotics and fluids within 60 minutes. And so they'll actually manually put that in. At risk, for more details on that, that specifically applies right now to if you have a central line access, fever and oncology, fever and transplant, fever and dialysis, fever and sickle cell, fever less than 60 days of life. Those are all kind of in our at risk for sepsis patient population. So that's that part. Sepsis huddle. So you have a sepsis huddle, 15 minutes within it being triggered with the ED faculty and RN, and they determine if the kid is green, yellow, red. So green is, hey, this is not sepsis. This is not organ dysfunction, and screen. Or you can have red. This is sepsis. I'm concerned about this. Put in the order set and screen. The order set it has the fluids and antibiotics, which should be administered within 60 minutes per the Surviving Sepsis Campaign guidelines and IPSO recommendations. Okay. And then it also has like your nursing vital sign assessment minimum, which is every 15 minutes at the minimum. Usually it's a lot more than that, but that's the minimum. Now, yellow zone. Yellow zone is the mystery box. This is why we don't have a standardized screening tool in peds for early identification of sepsis, because it's a mystery still. So this box gives you a lot of leeway to do different things. This box can say, hey, this kid has fever. They're a little tachycardic. They kind of look a little punky. I think it might be the fever though, and not anything else. Let me give them Motrin and reassess them and see what they do. 60 minutes later, every 60 minutes, you get a rehuddle on these patients in the yellow box to see if they're still there elsewhere. And you're like, rehuddle, and you're like, nah, they're jumping around the room. They're bouncing off the walls. This kid's effervescent, and they look phenomenal. Okay, it was the fever. Good. You're good to go home. Or you're like, man, this kid still doesn't look good. Something's up. Let's go ahead and do a workup. So it gives you some wiggle room. Additionally, this is where a lot of your at-risk patient population goes. And again, you order your sepsis at-risk order set, and within 60 minutes, they should get their workup done. Vital signs for the at-risk patient population or for your sepsis watchers, your yellow box are every 30 minutes. Lastly, at any point during the ED stay, if they trigger nuance at hypotension, so any patient ED nuance at hypotension, it automatically will trigger a sepsis screening tool. Okay, that was a lot, but that's kind of how our screening goes right now. You don't have to read this, but no, there's a sepsis huddle process for all our ED holds as well that have been verified or an agreement with our other services. And some of y'all inpatient services might have gotten it before or not, but there is a process for sepsis huddles on boarding patients in the PED. So next, so this is our order set. We have one order set for all sepsis and at-risk patients. The reason is it's one name, one order is easier to remember than a bunch of different ones. So it leads to increased compliance, and also it's easier to track. So it's PED sepsis / at-risk. When you open it, there are a bunch of different subcategories that you can click from, all with associated clinical pathways, and we'll get to those in a bit. Additionally, you'll have your nursing assessment, your watcher and suspected sepsis. You'll have your sepsis time span as well. We talk about clinical pathways. Clinical pathways, residents, they save lives. So what can I say? They truly do. The clinical pathways, standardized care, so everyone gets evidence-based medicine. It's especially important in places like university where we have providers of different backgrounds. We have PEM, we have EM, we even have EM fellows sometimes, and also learners from different backgrounds, PGY 1, 2, and 3 from family medicine, EM, and pediatrics. So it helps kind of everyone know we're all doing the same thing. Additionally, and I cannot emphasize this enough, these are great educational tools, residents, for you to learn about a disease process, how we treat it, and the basics of a process, with lots of bounce-off questions from there. So labs. I've gotten a lot of comments about this. So when we did the order sets and clinical pathways, the Phoenix score had just come out, and we thought it'd be really interesting to go ahead and include the Phoenix score labs within those order sets. We did it, of course, for like your generalized sepsis, but we also did it for at-risk patient population because we thought it'd be interesting to track. And for those of you who are not in the receiving end or not familiar with some of those labs, we typically don't order coags and D-dimer and lactate on a well-appearing kid, but the Phoenix score requires that those be part of it to obtain the score. And so we thought, hey, this might be interesting to track. Like in the ED, they're a score of 0, and on day 3 or day 2, they have a Phoenix score of 2. That was the intent. It's had some unintended consequences, and that we've had some providers misinterpret the lab, specifically the D-dimer. We've had a bunch of providers from the adult side unintentionally interpret the D-dimer for pulmonary embolism things and other etiologies. So we're working on that. Will we always keep it in the at-risk patient population? If they look okay, we always make it automatically clicked, or we maybe in the future will make it opt-in. To be determined. We'll talk with the sepsis work group about that, but that was the intent behind that. This is where you can score the Phoenix sepsis score in Epic, and then there's scoring tools. Also, truthfully, MedCalc makes it super easy. MedCalc's easier to use, and you can just calculate in there and put it in Epic as well. Okay, so now I've talked about how we do our sepsis screening at university. Let's talk about how we're tracking it with the IPSO. Okay, so every month the sepsis work group gets this email. The data is abstracted through Epic and Midas. So processes. This is a busy screen. Don't worry, you don't have to read it. Just know, hey, there's 12 graphs and tables they're looking at. Awesome. That's a lot of stuff. So these are the process measures we're looking at. How often are the OPAs firing? How often are nurses completing the OPAs and the sepsis huddles. What are the outcomes of those? Green, yellow, red. What are the dispositions? What are our time to antibiotics? What are our time to fluids? What is our ED disposition? Okay, that just kind of skims it there. And then these are some of the outcomes. So our outcomes, what are what is our, how many, and this goes, and this, some of this is being pulled, the prior screen was pulled from Epic. This screen, some of it comes from MIDAS, which is a program that tracks safety, risk management, and clinical data. I'm not as familiar with MIDAS, but this is how they're getting some of the mortality associated with sepsis. And then we even have it for like, was it present on arrival? Was it not present on arrival? And we're learning more and more about the outcomes page specifically regarding sepsis mortality as we speak. So on that note, let's actually talk about our mortality levels now. So in 2025, so this process has been rolled out now for almost a year, and our mortality rate is 7%. So that's awesome because previously it was 13 and 16%, and the national average is 8%. So excellent job, team. I think there's a lot of factors at this. Before we go into that, let's talk about a little bit more about this number and what that means, because we're still trying to learn about that. So it pulled 7%, 7 patients mortality rate that had somewhere in their chart at some point in the chart, the name sepsis. When we actually pull those patients and look at those patients' charts, only 2.7, so only 3 of those patients actually had sepsis attributed mortality. So this is where it gets challenging because sometimes the automated data abstraction isn't always the most accurate. And so, for example, last month, the team got 3 patients to review to determine if they were sepsis or not sepsis. 2 of them were not mortalities, and it was like a kid that had a mucus plug and got discharged the next day. One was a kid that had a foot abscess and got admitted for an IND with podiatry, and a resident one point put sepsis in the chart, but they were discharged the next day. Like both of those were not sepsis, right? But somehow they got it like coded. The coding data abstraction got their names. And then the mortality was a kid that aspirated on a grape at home, and the grape was removed by EMS, and he came in coding, right? Like that's not a sepsis attributed mortality. So I don't know how that got into there. Why I'm saying this is data abstraction is not perfect, and we're working on trying to fine tune it. And so that's how you go from 7 to 3%. Is that when we actually look at that 7% is what is being pulled for everyone for comparison with IPSO, but that 3% is really more reflective of what's going on at our institution. And even if we're not sure about how those numbers are being pulled, we can say, hey, over the past 3 years, our inpatient encounters have uptrended. Our final diagnosis of sepsis has uptrended, and our mortality has overall downtrended. So I do tend to believe that our mortality rate truly is going down, with that being said. So excellent job, university. We're making progress. Okay. So next steps. So this has been rolled out in the PED. Dr. Shanley and the sepsis team are now starting to work on inpatient processes for inpatient screenings. And so you'll start hearing more and more about that on your end if you haven't already. Now the future. What is the future of sepsis? So when we talk about sepsis, it is a complex biological process made up of a whole slew of pathogen and host factors. And what differentiates sepsis from an infection is the presence of a dysregulated host response and organ dysfunction. So again, super important, we're going to repeat that. Sepsis is a complex biological process made up of a bunch of host and pathogen factors. And what differentiates sepsis from infection is the presence of a dysregulated host response and organ dysfunction. So our current definition of sepsis is way too simplistic, right? So on that note, what's the future? So we need improved screening tools. We need screening tools with high sensitivity and reasonable precision, okay? It needs to be adaptable to different healthcare settings, right? And it needs to be applicable to all ages and those with and without chronic conditions, okay? So we're actually making some progress on that. We're going to probably start using a lot more computer models for this. And so in 2024 JAMA, they actually had a study they published using a computer model, the derivation and validation of predictive models for early pediatric sepsis. Now, this is not prime time. This is not prime time, but it's a step in the right direction saying, hey, we're going to start using computer models to try to get better screening tools for identifying early sepsis. And this article was really interesting because they took patients in the ED and said, hey, you don't have sepsis in the first 4 hours, but you go to develop sepsis in the next 48 hours. How do we identify a tool that identifies you? So in the future. We didn't even talk about preterm and neonatal infections, and none of our numbers even include the newborns or neonates. So that's another discussion. We need to design studies that incorporate phenotype-based criteria reflective of individual biology. So we probably need in the future, maybe we'll have some targeted therapies for different subtypes of individuals. So for example, right now, sepsis is kind of all clumped in the same category, whether it's the infection at the site of end organ damage versus infection with end organ damage at a different site. Those are presumably probably two different processes or processes with some differences, right? And so we might have more targeted therapies for those. Next, an improved understanding of the host response. So the pro and anti-inflammatory responses, modifications to non-immunologic pathways. And then lastly, test efficacy and effectiveness of novel clinical and molecular markers that can assist with delivering targeted antimicrobial therapy, right? So antibiotic resistance is a big thing. How do we do more targeted therapy? Now, on that note, so far we've talked about screening, tracking, and definition of sepsis. I specifically not talked about treatment of sepsis. I think that is a different presentation. That was not the point of this presentation. However, I oftentimes have residents ask me all the time, how do I treat sepsis? How do I treat sepsis? And so this is a plug for them, just a quick plug. If you want to learn about treating sepsis, please read the Surviving Sepsis campaign. They have a long version and they have a short version. Take your pick. But it's a wonderful document that really goes into like how do we treat sepsis and a little bit more of the nuances of it. And it's very educational. If you want an even shorter read, if you have your PALS card, bada bing, bada boom, they're the ABCs to how to do sepsis at bedside, okay? If you're inpatient, I always carry my PALS card with me on every shift. I recommend you do 2 pediatric residents, and the PALS card will help you there. There's also a clinical pathway that university has for sepsis. It's somewhere on the internet, and it's also in the ED binder that's on the doctor desk. And on that note, I'm done.
Thank you, Dr. Schwartz, for that great overview on a topic that I fortunately don't see often, but I know many people in the audience do. I'd like to open up to for questions. You can either place in the chat or raise your hand and mute yourself. See Dr. Sugalski with his hand up.
Ooh, yeah.
Hey, Whitney, good or excellent talk. And so I love you here. A lot of high points. I love the history and all that sort of stuff. I don't know if I'd say you're my favorite residents, but you're one of my most memorable residents. So I think that's hard to say. But I do remember every time you call in the middle of the night because it wakes me up immediately. So anyways, how good are we? So I love the data on, decreasing mortality and so forth. So because there's such a variety of providers in the ED, especially days and nights and so forth, how good are we at actually activating the right order set for these patients when they come in? Because I think that's probably the first step. Do you have data on that?
I don't have it off the top of my head. I know that we've done a bunch of education for the ED, to be like, hey, please use these order sets, and the nurses too. I don't know. I should probably look. I'm sure it's on one of those graphs that I just didn't look at. I can collect that data. I don't know. Are you seeing a lot on your end where people aren't using it, or what are you seeing on your end? This is helpful information for me.
Yeah, no, I don't think so. I'm just curious. Like, I mean, I feel like our patients, that come in with fever and neutropenia or fever and a port, that sort of stuff, they get this pretty regularly. I mean, the workup and
Yeah.
antibiotics is the most important thing. And so
Yeah.
like, that's the deal. So like, I
Yeah.
think for us, it's probably done, majority of the time.
Yeah.
So,
I
mean, a
think
good majority.
when we first started the rollout, I knew we did have we did recognize that not everyone was using the order set. I think more and more people are using the order set. I need to go back and see what is our compliance with the order set now that we're 12 months in. So I can do that, but hopefully the education's helping.
Great. Good job.
We got Dr. Asanasan, then Dr. Medellin.
Hey, Whitney.
Hey.
Great talk. Hey, I'm actually kind of interested in the dashboard and the data you've been collecting.
Okay.
In light of the different populations, how well are you able to kind of sort out between the severely immunosuppressed patient populations in that dashboard, as well as the data you're collecting, as well as kind of the foot abscess you're talking about, and as you mentioned, the neonatal group that you haven't really kind of dived into yet.
Yeah, that's a great question. So we actually, you didn't see on this file, but the Excel file actually, if there's any fallouts anywhere, it has attached MRNs with it, and the mortality patients all have attached MRNs as well. And so we actually, in the monthly meetings, we'll actually go through any fallouts in there. None of the neonatal patients are included in any of this data, so that's automatically excluded. In terms of differentiating severely immunocompromised versus non, we would have to individually go through those MRNs to do it. But we do have, there is a way to track, and like you theoretically you can go in and track between the severely immunocompromised and not. You would just have to build that out a little bit
So
more.
right now they're mixed together. So there's kind of a couple of different populations in that dashboard with regard to downstream effects, et cetera. And just because the initial criteria is probably going to be a little bit different between as Aaron mentioned, on severely immunosuppressed oncology, fever, neutropenia patient coming in versus foot abscess.
Yeah. So the foot and so where I think there's two different things here. There's the processes one and the outcomes page. The processes page is we've been tinkering with that a lot. That's via Epic, and so we have a lot more control over that with our Epic analysts. And so for the processes page, that's a lot of the OPAs, time to antibiotics, time to fluids. The outcomes page, a lot of that is abstracted from MIDAS, which is a different program, which I'm not quite as familiar with. And MIDAS abstracts it. So I'm understanding MIDAS gets its data from final diagnosis or any diagnosis during the time of the hospital stay. And you get that data within 5 days. And so that's where we're getting the mortality data from. And because it is so much smaller, we actually do look at all those patients to get more information on them. And that's how we were able to go from the 7 patients mortality to the 3 patient mortality. And then anything that comes up through MIDAS with the sepsis, like final diagnosis code. So there were 91 final diagnosis codes for 2025. And when we get those, we screen for them and say like, yes, this is sepsis, or no, that's not sepsis. So like last month when we got the 3, we said, no, 2 of those are not sepsis. Those aren't sepsis. Or actually 3 of those, none of the 3 that were flagged were sepsis related. And so we can take those out. So it doesn't, in doing that, you do know if it's immunocompromised or not immunocompromised patients, but in our one to that is kind of differentiating like, hey, did we get inappropriate sepsis pulls into the sepsis MIDAS tracking or not? And then we can take those patients out. I don't know if that answered your question or not.
Yes, thanks.
Dr. Medellin.
Hey, Whitney, I'm always so thankful when y'all evaluate my special patients down in the ED. I guess, how do my kids with autonomic dysfunction baseline with abnormal, low temperatures, neurologic dysfunction, how do these kids fit into these pathways?
That's a great question. Usually we err on the side of caution and we'll either put them in the yellow or red box, depending. If they have a known history of autonomic dysfunction, we'll probably put them in the yellow box. If the provider isn't aware, they might unintentionally do the red box. But they usually do get workups because they are so complex. And those patients specifically, I feel like just are sneaky with their sepsis, right? And so they'll usually get in the yellow box and get a workup done.
Yeah, although I do see a lot of variability when it's a PD ED doc on, there's often a workup, but no antibiotics and no running down the full
they might
treatment
be in that
pathway.
yellow.
And then, an adult docs usually are. Yeah, sorry.
Oh, sorry. Go for it.
No, I just say if it's an adult ED doc, I often have a full treatment pathway, and they're in the red box for sure.
Yeah. I think it's different levels of comfortability, I think. So yeah.
Okay, thank you.
Quick question in the chat box, then we'll get to Dr. Canty. Dr. Myers asking, are we stocking pre-dose antibiotics for different weights in the ED to maybe be able to give them more rapidly?
So actually super glad you asked that question, because that was a big problem. Prior to this, the nurses were not allowed to give antibiotics. They were not allowed to mix the meds at bed, which was kind of crazy because I'd always had nurses be able to mix the meds at bed. And so part of this initiative is we got approval to do 7-PM-7 we can mix at bedside. So 7-PM-7 we can pull from the Omnicell and give ourselves for more rapid administration to meet our timeframes. We can't do it for Vanc or for Zosyn. And then for amp and gent for the neonates, pharmacy did not want us doing it just because it's such small volumes, like small errors can be big mistakes. And so pharmacy does amp and gent for us, but we can do cefepime-7.
Dr. Canty?
Hey, Dr. Schwartz, great presentation. I have one comment and one quick question. The comment is, I mean, just in the last 10 minutes that you've been answering questions, you've had a nephrologist, a oncologist, an intensivist, another intensivist, and now a neonatologist. So I just wanted to congratulate you on having a system and a tool that is able to handle all that heterogeneity and still make it super simple and understandable. That's a lot easier said than done. So well done on that. That's my comment. My question is, can you just briefly talk about how's the workflow? Like, is the huddle been pretty well received? Do you get pushback? Are people rolling their eyes? Like, how does it work down in the trenches?
Yeah, so actually it's not been bad because that was our big concern initially is how many of these huddles are we going to get pulled for? And it's not as often as one thinks. So that's really helpful. And we're also measuring that too. Like, are we in our processes, like how often are you getting like a sepsis huddle called? It's not that often. It's not often enough to cause a problem. So not alert fatigue. That's great. I don't think we're getting pushback. I haven't heard any pushback from other providers, or let me rephrase that. I haven't heard nurses say that other providers are giving pushback. So I think it's being well received that way. And I think it also helps when we like go to the ED and say like, hey, these are our numbers there. We need to improve. It's kind of like, okay, yeah, we got to make some progress.
Additional questions from the audience? While we're waiting, I was going to kind of piggyback on that comment, and then we'll get to Dr. Lopez. I guess, do you think that for certain groups, like say my patients, especially patients, that might be one possible barrier or cause of delay for implementing these steps, waiting for callback from the specialist because they're worried about a certain issue? Or have you gotten that feedback?
I haven't
Just
gotten
hearing
it.
a couple of patient experience. Sometimes things are slower, but may not, there's many things going on in the ER all at once. So I just want to make sure
Yeah,
that wasn't a barrier for you guys.
I don't think so. I think so when the specialty patients come, like on the board, the tracking board, if they're at-risk patient population,
Oh no, did we just lose
survival.
Dr. Schwartz? Oh, there
Oh,
you go. You're
no, no,
back.
no. Okay,
You're
I'm
back.
back.
You're back.
So when an at-risk patient arrives, they're triaged as a triage level 2, which 1 is you're dying, 2 is you need to see within 30 minutes, 3 and 4 and 5 is like you shouldn't be there, right? So they're triaged at a 2, so I should see them within 30 minutes ideally. And so we always try to get those order sets in as soon as possible. So the order sets are usually put in pretty rapidly. A lot of times it's the delay in waiting for the ultrasound results. Like ultrasound can take forever to come back, especially in the middle of the night. And RADS is, I'm sure y'all are familiar, RADS is, they're working on some of their times, but in the middle of the night, ultrasound reads can take forever. And so, or sometimes waiting on some of the final labs can take a long time. So I think probably a lot of that delay is either, I'm curious, I don't think it's putting the orders in. I think it's waiting for the results that's taking a long time. But never waiting for the consultants are always super fast on answering their phones and responding to us.
Glad to hear that. Thank you. All right, Dr. Lopez, go ahead.
Hi, Whitney. Really, really good presentation. I will be the outpatient representative for now, so you can check all your boxes and everybody who is interested in the talk. So you really went through it all really well for this topic, and I know you're involved also with asthma, and so kind of as a teaching point, I guess for our residents, and especially those who want to go maybe into academia or fellowship. Like how many other like disease processes have you worked on in the emergency room? And is this like reimbursable time for you, or
Ooh,
you're
that
doing
is
it
a
in your own time?
that is a
Mhm.
great question, Dr. Lopez. I will gladly let the residents know what I did. So when I came back to university, I let me make sure I state this the right way. I knew the PDED had a lot that needed to be done. And I wanted to be able to do that thing, but also maintain my mental sanity, right? I have 4 kids. I enjoy my job. I want to be able to like do my job and make it better and have the bandwidth to do it all. So I negotiated protected time to do quality improvement. And so that was actually part of my contract. I got a shift buy down to do quality improvement. And so this is part of my job, is do quality improvement.
That's awesome, because that was actually the last part of my question. Do you think it increases burnout, or it helps you overall?
Ooh, that's great. I love this stuff. I think it helps overall. And I remember in fellowship, my faculty would tell me like, Whitney, having a niche in medicine, like backtrack, my faculty would tell me if you just do the day-to-day EM stuff, you're going to get burnt out. It's going to get old. You're going to get burnt out. But if you have a niche, it keeps you in the game longer. And I definitely find that to be true. Like, I like the quality improvement stuff. It also honestly makes my job in the ED better. It's safer. It's better workflow. It's better overall because the whole system's improving. So I like it because it's fun to do and it feels like there's a mission. And I also like it because clinically it makes my shifts that much easier as well. But I do say like everyone needs to have a niche in medicine, and that niche can change throughout the years, but the niche will keep you engaged and to keep you from being burnt out, whatever that niche might be.
Thank you so much.
Fantastic points, especially in this current environment of medicine. So, all right. Additional questions or comments for Dr. Schwarz? Okay. Well, if not, thank you again, Dr. Schwarz, for presenting to our team. So glad to have you back. Glad to see you're just as awesome as you were many years ago as a trainee. So, um, for the audience, please don't forget to place your attendance code, which is in the chat if you still need it. Also, please don't forget to complete the post-grand round survey that helps Dr. Schwarz with feedback and also helps support our program. Otherwise, thank you again, Whitney. Great to see you, and you guys have a great rest of your day.
Thank you.